In this presentation, the techniques for the intramedullary fixation of a proximal femoral fracture will be demonstrated using the TFN Advanced Proximal Femoral Nailing System, or TFNA. This presentation uses a short TFNA nail with a helical blade to demonstrate the dynamic and static proximal locking options. The TFNA system includes long and short nails. Long nails are available in lengths ranging from 260 to 480 mm in 20 mm increments, with distal nail diameters of 9, 10, 11, 12 and 14 mm. The long nail provides 3 distal locking options. These include a unique oblique distal hole, which has an offset angle of 10 degrees. This angle allows the stronger bone in the condyle to be targeted. Multiplanar locking offers increased stability. Short nails are available in lengths of 170 mm, 200 mm and 235 mm, with distal nail diameters of 9, 10, 11 and 12 mm. There is only one distal locking option for short nails. All TFNA nails can be locked with either a screw or helical blade. The helical blade is designed to compact the bone around the blade during insertion, which enhances anchorage and may reduce the risk of cutout. The screws and helical blades are perforated, allowing augmentation of fractures in the proximal femur, which have a greater risk of fixation failure at the implant-bone interface and/or poor bone quality. After blade or screw insertion, the system allows for dynamic and static proximal locking modes. In the dynamic mode, the set screw within the locking mechanism is advanced with clockwise turns down to the stop. It is then backed off by a counterclockwise half turn. This locks the helical blade or screw in rotation, but allows it to slide. Dynamic locking is indicated for the vast majority of fractures, as it allows for interfragmentary compression at the fracture site during post-operative mobilization. In the static mode, the set screw within the locking mechanism is advanced with clockwise turns and final tightened with a torque limiter. The helical blade or screw is now locked in rotation and cannot slide. Clinically, each step of this minimally invasive procedure is verified under image intensification. This presentation focuses on the dynamic and static proximal locking options for the short TFNA nail using a helical blade. Upon completion of this exercise, you should be able to identify the clinical indications and contraindications, describe the correct patient positioning, identify the correct entry point, and explain the steps used to perform the surgical procedures. Indications for the use of TFNA short nails include cases where there are stable and unstable paratrochanteric fractures 3-1-A1 and 3-1-A2, intertrochanteric fractures 3-1-A3, and a combination of paratrochanteric and intertrochanteric fractures. Contraindications for the use of TFNA short nails include cases where there are medial femoral neck fractures 3-1-B, femoral shaft fractures 3-2-A, B, C, and subtrochanteric fractures 3-2-A, A2, A. The patient is positioned supine on a radiolucent or traction table. A traction table is used in the vast majority of cases. The upper part of the body is abducted approximately 10 to 15 degrees to the contralateral side, or the affected leg is adducted by 10 to 15 degrees to allow for unimpeded access to the medullary canal. The image intensifier is positioned to enable visualization of the proximal femur in both the AP and lateral planes. The unimpeded movement of the C-arm is verified before draping to ensure the efficacy of intraoperative radiographic imaging. After the fracture has been reduced, the next step is preoperative planning. The instruments required are the radiographic ruler and the guide wire diameter 3.2 mm, length 400 mm. The caput column diaphyseal or CCD angle is determined by placing a guide wire in line with one of the grooves marked 125, 130 or 135 degrees at the proximal end of the radiographic ruler. The central position of the guide wire in the femoral head is verified under image intensification in the AP view. Note that the guide wire is inserted into the angle which best matches the angle of the femoral head and position of the radiographic ruler. In this presentation, the guide wire is placed in the groove marked 130 degrees. The proximal end of the radiographic ruler corresponds to the proximal end of the nail after insertion. The slot on the proximal end refers to the path of the guide wire, which will be used when opening the femur. All AP images of the proximal femur are made with correction for the anteversion, either by internally rotating the femur or by adjusting the image intensifier. Note that internal rotation of the femur can lead to malrotation of the fracture. In the clinical situation, the reduction is verified and corrected if necessary under image intensification before distal locking occurs to avoid malrotation, and the position of the radiographic ruler at the proximal outline is marked on the skin to assist the next steps. The nail diameter is determined by repositioning the image intensifier for an AP view of the femur at the level of the isthmus. The estimated diameter is measured from the circular indicator that fills the canal. In the AP view, the nail insertion point is on or slightly lateral to the tip of the greater trochanter, which is 5 degrees lateral from the axis of the femoral shaft. This corresponds to the design of the nail. In the lateral view, the entry point for the nail is centered in the greater trochanter and in line with the medullary canal. The instruments for guide wire insertion, the correction of an incorrectly positioned guide wire, and the opening of the medullary canal are the guide wires, diameter 3.2 mm, length 400 mm, the multi-hole drill sleeve, the protection sleeve, the drill bit 16 mm, cannulated, and the hollow reamer, cannulated, diameter 16 mm. The guide wire is inserted. However, it can be seen that the position is incorrect, as it is too anterior and too lateral to the tip of the greater trochanter. If the guide wire is incorrectly positioned, the multi-hole drill sleeve is used to establish an offset of 4 or 6 mm. A second guide wire is inserted through the hole of the drill sleeve at the correct entry point. The multi-hole drill sleeve and the misplaced guide wire are removed. After inserting the multi-hole drill sleeve into the protection sleeve, the assembly is slid over the guide wire down to the bone, and the multi-hole drill sleeve is removed. The flexible cannulated drill bit, diameter 16 mm, is slid over the guide wire through the protection sleeve to the bone, and then drilled to the stop. As an alternative, the hollow reamer can be used to open the medullary canal. The hollow reamer removes a bone plug and creates an opening which has a diameter that matches the nail diameter and helps avoid fracture displacement during nail insertion. The cannulated hollow reamer is pushed from the coupling end towards the cutting end of the instrument to select the correct position of the centering mechanism. The hollow reamer is guided through the protection sleeve to the bone and drilled to the stop. The passage of the hollow reamer is monitored under image intensification in both AP and lateral planes. In the case of a narrow medullary canal, reaming may be necessary in order to allow for proper nail insertion. The instruments for nail insertion are the screwdriver, hexagonal, diameter 8.0 mm, T-handle with spherical head, length 322 mm, the connecting screw for insertion handle, the insertion handle, the aiming arm with locking insert, the guide wire, and the drill sleeve 5.6 3.2, length 198 mm, for the insertion of an anti-rotational wire. The hexagonal screwdriver with spherical head is attached to the connecting screw until it clicks into the recess. The geometry of the handle is matched to the nail, and the nail is connected to the insertion handle. The nail clicks in and is now self-retaining. The connecting screw is passed through the insertion handle and securely tightened with the hexagonal screwdriver with spherical head. The hexagonal screwdriver is now removed. The insertion handle is oriented laterally, taking into consideration the anteversion of the femoral head and neck, and manually inserted into the femoral opening. Insertion of the short nail should not require hammer blows. The fracture reduction is verified under image intensification. The aiming arm is now securely attached to the insertion handle by tightening the thumb screw. A guide wire is inserted through the hole marked nail end under image intensification. The tip of the guide wire indicates the exact proximal position of the nail, and the length of the end cap can be determined. Under image intensification in the AP position, a guide wire is placed on the yellow marking of the aiming arm to estimate, and if necessary to correct, the depth and position of the blade or screw. As an alternative, the aiming device for the guide wire can be used. To do this, the image intensifier is positioned for an AP image and then rotated until any two dashed orientation lines are parallel to the proximal locking hole. The solid line in between the two orientation lines represents the guide wire trajectory. The image intensifier is positioned in a true lateral view, aligning the axis of the femoral neck congruent with the axis of the femoral shaft. Note that the anatomically true lateral view is achieved by rotating the image intensifier 10 to 15 degrees to correct for anteversion of the femoral neck. The nail is rotated under image intensification until the guide wire projects in a centered position over the femoral neck. In order to provide a correct estimation of nail rotation and anteversion in relation to the femoral neck, the two radiographic lines on the insertion handle must be parallel to the nail. In very unstable fractures, an additional anti-rotation guide wire can be inserted. This anti-rotation guide wire secures reduction, preventing malrotation during screw insertion and over-insertion of the implant. In order to do this, the drill sleeve 5.6 3.2 is inserted through the corresponding anterior or posterior hole on the aiming arm to the bone. A guide wire is inserted through the drill sleeve into the femoral head, and its passage is monitored under image intensification. Note that the guide wire will converge towards the tip of the helical blade or screw without contacting it. The guide wire is used for provisional fixation only and is removed once the helical blade has been inserted. Proximal locking begins with the insertion of the helical blade or screw. The instruments required are the trocar with yellow marking, the drill sleeve with yellow marking, the guide sleeve with yellow marking, the buttress compression nut, the direct measuring device, the drill bit for lateral cortex opening, the rod pusher, the TFNA helical blade impactor, the connecting screw for TFNA helical blade and screw, and the combined hammer. The guide sleeve is assembled by first inserting the drill sleeve and then the trocar. The buttress compression nut is threaded onto the guide sleeve up to the black marking. The guide sleeve assembly with yellow markings is inserted into the aiming arm until the buttress compression nut clicks into the locking insert. The buttress compression nut is turned counterclockwise to advance the guide sleeve to the bone, and the passage is monitored under image intensification in the AP view. The nut is not over-tightened, as this may affect the accuracy of the aiming assembly. The distal tooth of the guide sleeve should rest on the lateral cortex. To attain the correct position of the distal tooth, the yellow markings on the top of the guide sleeve must be aligned to the yellow mark on the aiming arm. To help prevent the guide wire from slipping off the bone, the trocar can be lightly hammered to create an indentation in the bone. The trocar is removed and a guide wire is drilled through the drill sleeve into the bone. The guide wire is advanced into the femoral head, stopping approximately 5 to 10 millimeters below the joint level. Under image intensification, the passage of the guide wire is monitored to ensure that it is centered in the femoral head and neck in both the AP and lateral planes. The tip of the guide wire is positioned where the tip of the head element will be when properly inserted. The direct measuring device is passed over the guide wire and the blade length is read. The measurement is calibrated from the tip of the guide wire to the tip of the tooth on the guide sleeve. The drill sleeve is removed. The drill bit for lateral cortex opening is guided over the guide wire and drilled to the stop to open the lateral cortex. With dense bone, or when using a screw, the stepped reamer is used to prepare a path for the full length of the implant. The rod pusher is used to avoid displacement of the guide wire while removing the drill. If the guide wire is removed inadvertently, it should be reinserted under image intensification to avoid misplacement of the blade or screw during insertion. Care is taken to ensure that the orientation of the insertion handle and aiming arm is not altered. The helical blade is recommended in cases of poor bone quality as it allows for bone compaction around the head element and prevents the bone loss that occurs with the drilling and insertion of the standard hip screw. Both TFNA blades and screws are perforated, allowing for augmentation if necessary. The connecting screw is threaded until it is fully captured in the helical blade impactor. The connecting screw is attached to the instrument. The helical blade impactor assembly is passed through the guide sleeve, and the red line on the impactor shaft is aligned with the red line on the guide sleeve. The helical blade is advanced manually as far as possible. The assembly is lightly hammered until the impactor comes to a stop at the back of the guide sleeve. Image intensification is used to monitor positioning during the helical blade insertion. At this stage, the yellow line on the guide sleeve is in alignment with the yellow line on the impactor, indicating that the helical blade is fully inserted. Be aware that the helical blade must be fully inserted. The instruments for dynamic and static locking and interfragmentary compression are the screwdriver, hexagonal, 5.0 mm, flexible, cannulated, the static locking screwdriver assembly, which consists of the T-handle, cannulated with quick coupling, hex 12 mm, the torque limiter, 6 Nm, and the screwdriver shaft, hexagonal 5.0 mm, with hexagonal coupling 6.0 mm for static locking, and the pin wrench. For dynamic locking, the flexible screwdriver is passed through the insertion handle until it is seated in the hexagonal recess of the set screw which locks the blade. The set screw is advanced with clockwise turns of the screwdriver down to the stop. At this stage, the blade is statically locked. The set screw is then backed off by turning the screwdriver counterclockwise a half turn. The helical blade is now locked in rotation but can still slide. This allows for controlled collapse and compression of the fracture. The oblique lateral end of the blade or screw should lie flush or approximately 1 mm proud of the lateral cortex in order to avoid soft tissue irritation. Be aware that the lateral end of the blade must not lie under the surface of the lateral cortex, as this may prevent sliding of the blade. The anti-rotation guide wire and drill guide are removed. Interfragmentary compression is achieved by hand tightening the buttress compression nut with clockwise turns. A pin wrench can be used for additional leverage, but care should be taken to avoid over-compression. Over-compression can cause the helical blade to lose purchase in the bone, particularly in cases of lesser bone quality. In static locking mode, the helical blade is locked in position and prevents a secondary collapse of the proximal fragment. To do this, the torque limiter is connected to the T-handle and to the hexagonal screwdriver shaft. The static locking screwdriver assembly is passed through the connecting screw and insertion handle until it is seated in the hexagonal recess of the locking mechanism. The assembly is turned clockwise until the torque limiter reaches the optimal torque, which is felt and indicated by an audible click. The helical blade or screw is now statically locked. To remove the helical blade impactor assembly, the pin wrench is used to loosen it. The locking insert is depressed, unlocking the assembly, allowing it to be removed. The instruments required are the protection sleeve 11.0, 8.0, length 188 mm with green marking, the drill sleeve 8.0, 4.2 with green marking, the trocar diameter 4.2 mm with green marking, the drill bit diameter 4.2 mm calibrated, length 340 mm, 3-flute for quick coupling, the depth gauge for locking screws measuring range up to 110 mm, and the screwdriver star drive T25 self-holding, length 319 mm. The green triple trocar is assembled by inserting the protection sleeve into the drill sleeve, followed by the trocar. The assembly is inserted through the aiming arm to the bone. The trocar can be lightly hammered into the bone to create an indentation which will keep the drill bit from slipping off the bone. The trocar is removed, and the calibrated 4.2 mm 3-fluted drill bit is used to drill through both cortices. The drill sleeve is removed, and the depth gauge for locking screws is used to measure for screw length. The screwdriver star drive T25 is used to insert the appropriate 5.0 mm locking screw through the protection sleeve. At this stage, cement could be used to augment the stability of the fixation. The protection sleeve and aiming arm are removed. The instruments required are the screwdriver, hexagonal, diameter 8.0 mm, T-handle with spherical head, length 322 mm, the screwdriver, hexagonal, 5.0 mm, flexible, cannulated, and the guide wire. When bony ingrowth at the proximal end of the nail is of concern, the use of an end cap is recommended. In reverse oblique intertrochanteric and high subtrochanteric fractures, the nail should be slightly proud of the greater trochanter. If the nail has been over-inserted, it should be extended with an end cap of the appropriate length. End caps range from 0 to 15 mm in length in 5 mm increments. The rings on the insertion handle indicate the insertion depth of the nail. Starting distally, each ring is an additional 5 mm from the tip of the nail. The connecting screw is removed using the T-handle screwdriver with spherical head, while leaving the insertion handle connected to the nail. The appropriate length end cap is inserted through the insertion handle using the hexagonal screwdriver. A guide wire can be used to help align the insertion. The insertion handle is removed from the nail. The instruments required are the screwdriver star drive T40 with spherical head, cannulated, length 277 mm, the guide wire, diameter 2.8 mm, 460 mm length with hook, the screwdriver hexagonal 5.0 mm, flexible, cannulated, the extraction instrument for nails, cannulated, the interlock screwdriver, combined, star drive T25, hexagonal diameter 3.5, length 330 mm, the extraction instrument for TFNA helical blade and screw, the combined hammer, and the hammer guide. The star drive screwdriver T40 is used to remove the end cap, optionally assisted by using the guide wire with hook. To assist in the alignment of the nail extractor, a flexible screwdriver is passed through the nail extractor, which is engaged in the top of the nail. The nail extraction instrument is threaded into the top of the nail. The flexible screwdriver is removed. Next, the distal locking screw is removed using the interlock star drive screwdriver T25. Nail removal must not be attempted at this point. The helical blade must be removed before removing the nail. The helical blade extractor is threaded into the implant with counterclockwise turns. Then the hexagonal flexible screwdriver is passed through the nail extraction instrument until it engages the locking mechanism. The screwdriver is turned counterclockwise to the stop, which disengages the locking mechanism. Note that blade removal is only possible when the locking mechanism is completely disengaged. The combined hammer is slid over the helical blade extractor and lightly backslapped to remove the helical blade. Then the hammer guide is threaded onto the back end of the nail extractor. The combined hammer is slid over the hammer guide and is lightly backslapped to remove the nail. You should now be able to identify the clinical indications and contraindications, describe the correct patient positioning, identify the correct entry point, and explain the steps used to perform the surgical procedures.